This presentation about the pharmacotherapeutics is prepared by Professor Mohammed Abdelbari, Professor of Pharmacology, and Shamas Faculty of Medicine. The prepared narration is read by the Microsoft David voice. The term pharmacotherapeutics refers to all aspects of the drugs, which are related to the use of the drug in therapy. We are going to discuss two topics. 1. The therapeutic effects of the drugs, that is the useful effects obtained when the patient takes the drug. 2. The adverse effects of the drugs, that is the harmful effects that occur when the patient receives the drug for therapy. By the end of this lecture, you should be able to 1. Enumerate the types of therapeutic effects, and give examples for each type. 2. Enumerate the factors modifying the therapeutic effects. 3. Define tolerance, list its types, explain the possible mechanisms, with examples. 4. Define placebo, and list its indications. 5. Enumerate the types of drug interactions, give example for each type, and explain how it occurs. Let us start with the first item, the therapeutic effects of the drugs. There are four main types of therapeutic effects. 1. The curative effects, that is, the drug is used to completely eradicate the cause of the disease. The most famous example is using the antibiotics to treat bacterial infections, e.g., the use of amoxicillin to kill the typhoid bacilli, the causative organisms in typhoid fever. 2. The symptomatic effects, that is, the drug is used to alleviate the symptoms of the disease, without affecting the underlying cause, e.g., the use of acetaminophen, to control the headache, and lower the elevated temperature, which are associated with flu. The drug in this case makes the patient feels better, but it does not kill the virus. 3. The prophylactic effects, that is, the drug is used to prevent the occurrence of an expected disease, e.g., prescribing monthly injection of benzathine penicillin, for a young boy, who suffers recurrence of rheumatic fever, each time he catches streptococcal sore throat. 4. The replacement effect, that is, we give a drug to replace a deficient element in the body, e.g., iron, to replenish the iron stores, in a patient with iron deficiency anemia. The therapeutic effect of any drug is not the same in all patients. There are many factors that affect the intensity, and even the type of the therapeutic effect. Some of these factors are non-pharmacological, e.g., the age, sex, and race of the patient, or the presence of other diseases in the same patient, e.g., bronchial asthma, which makes the patient more sensitive to drugs that induce bronchoconstriction, as beta blockers, or muscle diseases, which makes the patient more sensitive to neuromuscular blockers. However, we are more interested in the pharmacological factors that modify the therapeutic effects of the drugs. From these factors, we have already discussed the most important one, which is the dose of the drug, in the pharmacodynamics presentation. Now, we are going to discuss three other factors. The first one is the tolerance. Tolerance is defined in three words. 1. It is decreased response to the drug. 2. That occurs on repeated administration. 3. So that the patient needs higher doses to get the full effect of the drug. Let us explain it with an example, A patient with bronchial asthma receives a drug called salbutamol to control its asthmatic attacks. When first used, the drug was very effective. However, after 1 month of repeated administration, the drug effectiveness decreased gradually. The patient was forced to increase the dose of the drug, in order to regain the initial effectiveness, once again. There are two main groups of mechanisms that can explain how tolerance occurs. The first is the pharmacokinetic group, which means that the drug fails to induce its usual effect, because the concentration of the drug that reaches the receptors becomes lower on repeated administration, either due to reduction in its absorption or distribution, or due to increase in its metabolism or excretion. This figure shows a cell membrane with 8 receptors. When we administer a certain dose of a drug called phenytoin, 4 of these receptors become occupied by the drug. This induces a certain degree of antiepileptic action. However, on repeated administration of the same dose, only 2 receptors are occupied, because the amount of the drug that reaches the site of action is reduced. One of the most important causes of this reduction is induction of the hepatic cytochrome P450 oxidase enzyme, with subsequent increase in phenytoin metabolism. The second is the pharmacodynamic group, which means that the drug fails to induce its usual effect, although the concentration of the drug that reaches the receptors is the same. One very important cause is the change of the number of the receptors on the cell surface. 2 famous facts about the receptors' number are known to all pharmacologists. 1. Repeated administration of an agonist reduces the number of receptors, a phenomenon called downregulation, and 2. Repeated administration of an antagonist increases the number of receptors, a phenomenon called upregulation. A very famous example of downregulation is seen on repeated administration of salbutamol in bronchial asthma. Most of the beta-2 receptors become internalized after binding the drug, thus, the number of the receptors available on the cell surface become too low to induce the initial bronchodilator effect, despite of the presence of excess molecules of salbutamol. A similar very famous example of upregulation occurs on repeated administration of the H2 receptor antagonist, ranitidine, to block HCl secretion in peptic ulcer patients. When ranitidine blocks some of the H2 receptors, the body synthesizes new receptors to replace the blocked ones. These new receptors get activated by histamine and overcome the effect of ranitidine. The patient is thus forced to increase the dose of the antagonist to block the newly synthesized H2 receptors. Another mechanism of pharmacodynamic tolerance is the activation of the body counter-regulatory mechanisms. E.g., if you give an antihypertensive drug to lower the elevated arterial blood pressure, the body will activate the sympathetic nervous system, which in turn induces renin secretion, i.e. salt and water retention, and accelerates the heart. These two counter-regulatory effects will re-increase the arterial blood pressure, and overcome the effect of the antihypertensive drug. There are 2 special subtypes of tolerance. The first is called tachyphylaxis, and the second is called Cross-tolerance. As regards tachyphylaxis, it differs from the usual type of tolerance, in 2 points. 1. It is acute in onset, that is, it does not need repeated administration, it can occur after a single dose. 2. It cannot be reversed by increasing the dose of the drug. The best example for a drug that induces tachyphylaxis is ephedrine. Ephedrine acts by releasing the stored norepinephrine from the sympathetic nerve endings. Depletion of stored norepinephrine can occur after a single dose of ephedrine, and thus, increasing the dose of ephedrine cannot resume its action. As regards cross-tolerance, it occurs to multiple drugs at the same time. These drugs usually act by the same mechanism. That is, these drugs are related to each other in chemical structure, so that they act by targeting the same receptor, or cellular component. If there is a problem with their target, all these drugs will stop to act. The best example for the drugs that induce cross-tolerance are the opioid analgesics. They act by activating the mu receptors. Downregulation of the mu receptors occurs on repeated administration of any opioid drug. This will prevent the other opioids from inducing their analgesic action. The second one is the placebo effect, which is related to the psychological effect of the drug. A placebo is a pharmacologically inert chemical substance, which is prepared in a dosage form that is very similar to that of a well-known active drug. It is used to deceive the patient, and makes him feel that he is treated with an actual drug. This is useful in psychotherapy, where the patient is not suffering from any organic diseases, and the placebo is used just to please the patient, and makes him feel that his disease is improved by an actual drug. It is also used when a new drug is being evaluated, and we want to make sure that the effect of the new drug is a true pharmacological effect, and not a psychological one. In this case, we divide the patients into 2 groups. One group receives the new drug, and the second group receives the placebo, of course with telling both groups that they are receiving a new very effective drug. If we get the same effect in both groups, then, we can conclude that, the new drug is not better than the placebo. The third one is drug interactions. Drug interactions refer to the modulation of the pharmacologic activity of one drug by the administration of another drug. Sometimes, this interaction is useful and intended, but in most cases, it is harmful and non-desirable. There are 2 types of drug interactions. 1. The pharmaceutical interaction, which occurs outside the body, that is, before drug administration. The best example occurs between penicillin and streptomycin, if they are wrongly mixed in the same syringe. 2. The in vivo interactions, which occurs inside the body, that is, after drug administration. This is further divided into 2 subtypes. The pharmacokinetic interactions, where the action of the drug is affected due to changing its blood level, that reaches the receptor sites, either secondary to changes in its absorption, distribution, metabolism, or excretion. An example of absorption interactions occurs between the antacids and the iron preparation. This is because of the antacid-induced decrease in the hydrogen ion concentration, which is needed for the absorption of inorganic iron. An example of distribution interactions occurs between warfarin and aspirin. This is because aspirin displaces some of the albumin-bound warfarin, thus increasing its free level in the blood. An example of metabolism interactions occurs between a cytochrome P450 oxidase enzyme inducer, e.g. phenytoin, and a drug which is a substrate for this enzyme, e.g. an estrogen preparation. This can explain the unintended pregnancy, which occurs in a female taking the oral contraceptive pills, when they are prescribed phenytoin, for long-term treatment of epilepsy. An example of excretion interactions occurs between penicillin and probenecid, where probenecid inhibits the penicillin secretory carrier in the kidney. This is a favorable interaction, and was once used to increase the effectiveness of penicillin. The pharmacodynamic interactions, where the action of the drug is affected without changing its blood level, that reaches the receptor sites. The new effect may be either less, or more, than its isolated effect. If the new effect is decreased, this is called antagonism, e.g., aspirin decreases the diuretic effect of furosemide. This occurs because part of the diuretic effect of furosemide is secondary to stimulation of prostaglandin synthesis, which is inhibited by aspirin. If the new effect is increased, this may be one of three conditions. 1. Summation, that is, the net effect is equal to the sum of the individual effects of both drugs, e.g., if you give diazepam, which induces a sedative effect, and the patient receives an antihistaminic, which also induces a sedative effect, the net sedation is equal to the sum of the sedation induced by each drug. 2. Synergism, that is, the net effect is greater than the sum of the individual effects of both drugs, e.g., you may give a vasodilator drug, or a diuretic drug, to treat hypertension. Each one, when given alone, lowers the blood pressure by 10 mm mercury. When you give the two drugs together, they lower the blood pressure by 25 mm mercury, which is greater than 20 mm mercury, which is the sum of their individual effects. This extra decrease in blood pressure by 5 mm mercury can be attributed to the correction of the salt and water retention, induced secondary to the vasodilation. 3. Potentiation, which has some similarity to synergism. It occurs when you have two drugs. The effectiveness of one of them, when given alone, is moderate. You have to add a second drug to improve the effect of the first one. However, this second drug completely lacks effectiveness when given alone. The best example is using clavulanic acid to potentiate the antibacterial effect of amoxicillin. This occurs because clavulanic acid protects amoxicillin from the destructive effect of the beta-lactamase bacterial enzyme. This presentation about the pharmacotherapeutics is prepared by Professor Mohammed Abdelbari, Professor of Pharmacology, and Shamas Faculty of Medicine. The prepared narration is read by the Microsoft David voice. The term pharmacotherapeutics refers to all aspects of the drugs, which are related to the use of the drug in therapy. We are going to discuss two topics. 1. The therapeutic effects of the drugs, that is, the useful effects obtained when the patient takes the drug. 2. The adverse effects of the drugs, that is the harmful effects that occur when the patient receives the drug for therapy. By the end of this lecture, you should be able to 1. Enumerate the types of adverse drug reactions, with examples. 2. Enumerate some of the mechanisms of the allergic reactions, with examples. 3. Enumerate some of the mechanisms of idiosyncratic reactions, with examples. 4. Enumerate the categories of teratogenic drugs, with examples. 5. Enumerate some of the mechanisms of withdrawal adverse effects, with examples. The second item in this presentation discusses the adverse, or the non-desirable, drug reactions. A nice classification is based, alphabetically, on the first letter in each category. The first category is Category A, where A is the initial of the word, augmented. This means that the adverse drug reaction is an augmented, or enhanced pharmacological effect of this drug. We reclassify type A into 4 subclasses, depending on the dose level which induces this adverse effect. 1. Drug intolerance, if the adverse effect occurs at very low dose, e.g., tinnitus, which may occur in an adult receiving baby dose of aspirin. 2. Side effect, if the adverse effect occurs at the usual therapeutic dose of the drug, that is, it occurs besides the therapeutic effect, at the same time. The best example is the dry mouth, which occurs when antihistaminic is used in treatment of common cold. 3. Overdose, if the adverse effect occurs at a slightly higher dose than therapeutic dose. A common example is bleeding that occurs if an excess dose of heparin is used to treat a thrombotic disease. 4. Toxic effect, which occurs with a suicidal doses of the drug. The best example is the fatal hepatotoxicity, which occurs when the patient takes more than 15 grams of acetaminophen. The usual dose of acetaminophen does not exceed 4 grams per day. The second category is Category B, where B is the initial of the word, bizarre. This type of interactions is unexpected, since it is not dose-related, that is, it can occur at any dose level. This type is subdivided into 2 subclasses. 1. The allergic reactions, or the hypersensitivity adverse effects, which will be discussed in further slides. 2. The idiosyncratic reactions, or the pharmacogenetic adverse effects, which will be also discussed in more details in future slides. The third category is Category C, where C is the initial of the word, continuous. This adverse effect occurs only after continuous, long-term use of the drug. The best example is renal damage, that occurs after years of continuous use of aspirin. The fourth category is Category D, where D is the initial of the word, delayed. This type of adverse effects may occur after a long time of stopping the drug intake. This type is re-subdivided into 3 subclasses. 1. Teratogenic adverse effects, which are the effects that occurs to the newly born infant, when the mother was taking a drug in the first 3 months of pregnancy. The teratogens will be discussed in more details in a future slide. 2. The mutagenic adverse effects, which are related to gene mutation, and may appear only after skipping of 1 or more generations, that is, the adverse effect does not appears in the children, but appears in the grandchildren. The anti-amoebic drug, metronidazole, is an example of a mutagenic drug. 3. The carcinogenic adverse effects. A famous example is lung cancer, which occurs in smokers, and cancers induced by radioactive drugs, which may not affect only the patients, but the medical and paramedical staff as well. The fifth and last category is category E, where E is the initial of the word end of dose. These adverse effects do not occur during drug administration, but occur after cessation of therapy, and will be discussed in more details in a future slide. Now, let us discuss in more details the types of allergic reactions, or simply the hypersensitivity. There are 4 different mechanisms for induction of hypersensitivity. The first type is termed the immediate type, since the reaction may occur as early as few seconds after exposure to the drug. This figure shows the detailed mechanism for the immediate hypersensitivity. The key cell is the mast cell, which appears yellow in color. They contain histamine granules, which appear as large red circles. In hypersensitive patients, these cells are armed with immunoglobulin E, which is bound on the cell membrane, and appears in the figure as green Y-shaped elements. When the mast cells are exposed to the antigen, which appears in the figure as blue circles, the immunoglobulin E antibodies bind to the antigenic determinants of the antigens, and this triggers degranulation of the mast cells, and release of histamine molecules, which appear as small red circles. This is the underlying mechanism for the penicillin-induced anaphylactic shock, as well as for the urticarial rash, which occurs with many types of drugs. Epinephrine is life-saving for the anaphylactic type, while antihistaminic drugs are enough for the mild reactions. Corticosteroids may be also used. They suppress the underlying allergic mechanism, however, they are slowly acting. The second type is termed the cytotoxic type, since it leads to death of normal, non-antigenic body cells. This figure shows the detailed mechanism for the cytotoxic hypersensitivity. Although the normal cells are not antigenic, they are converted into antigenic targets when they bind to the drug, which is called the hapten, and they appear as small blue circles. These cells can bind the immunoglobulin G and the immunoglobulin M on their surface. The phagocytes, which appear yellow, can bind the Fc segment of the immunoglobulins by special Fc receptors on their surface. These phagocytes can engulf the hapten-coated cells and digest them by their lysosomal enzymes, which appear within the large red vesicles. This is the underlying mechanism for the alpha-methyldopa-induced autoimmune hemolytic anemia, or autoimmune hepatitis. The third type is termed the immune complex type, since it entails the formation of antigen-antibody immune complexes in the circulation. This figure shows an orange-colored basement membrane of a small blood vessel, with pink endothelial lining. An interaction occurs between the antigen and the antibodies, to form soluble complexes, with subsequent activation of the complement pathway. This induces vasodilatation. This is the underlying mechanism for the vasculitis induced by the antithyroid thionamide drugs, e.g., methimazole. The last type is the delayed type of hypersensitivity. It occurs after repeated exposure to the drug. This type is mediated by activation of cytotoxic T lymphocytes, so it is also known as cell-mediated hypersensitivity. The most famous example occurs as local reaction on repeated topical application of neomycin. This type can be prevented by adding corticosteroids to the topical drugs, which are intended to be used for a long time. Idiosyncratic drug reactions are genetically determined adverse reactions that are unmasked only by drug administration. Pharmacogenetics is the field of pharmacology concerned with the genetic defects that underlie the idiosyncratic drug responses. In this slide, we will give some examples of the genetic defects that underlie some of the idiosyncratic drug reactions. The first genetic problem is the acetylation polymorphism. Acetylation is a conjugation reaction catalyzed by N-acetyltransferase enzyme, or simply NAT. Acetylation polymorphism arises due to the existence of two NAT isoforms, NAT1, which induces slow acetylation, and NAT2, which induces rapid acetylation. Approximately 90% in Middle Eastern people are slow acetylators. They are more liable to adverse drug reactions when they are treated by drugs which are metabolized by acetylation, for examples. 1. INH, or isoniazide-induced neurotoxicity. This was found to be corrected with administration of vitamin B6, pyridoxine, a cofactor for the NAT enzyme. 2. Drug-induced systemic lupus erythematosus, occurs with smaller dose and shorter onset, in slow acetylators, receiving more than 35 different drugs, many of which contain primary amino group. The most common are hydralazine and procainamide. Atypical pseudocholine esterase enzyme, which is synthesized by the liver and released to the plasma, to hydrolyze ester bonds, especially those of choline esters, e.g. succinylcholine. There are three variants: the W variant, which is the normal one, and the K variant and the S variant, which have 30% and 0% activity respectively when compared to the W type. These atypical plasma pseudocholinesterases can cause prolonged muscular relaxation, manifested as apnea, lasting several hours after succinylcholine administration. Glucose-6-phosphate dehydrogenase, or simply G6PD enzyme, is a RBC enzyme, needed for synthesis of reduced glutathione. Inheritance of G6PD deficiency is sex-linked, that is, the defect is fully expressed in affected males, and is never transmitted from father to son, but only from mother to son. In females, only one of the two X chromosomes in each cell is active. Consequently, female heterozygotes for G6PD deficiency have two populations of red cells, deficient cells and normal cells. Drug-induced hemolytic anemia occurs in G6PD deficient population, on exposure to oxidant drugs, e.g. antimalarials, sulfonamides, aspirin, etc., due to decreased glutathione synthesis. Mutation in ryanodine receptor, which is a part of the calcium channel, responsible for calcium release from the sarcoplasmic reticulum. Inheritance is autosomal dominant. Malignant hyperthermia is an inherited myopathy, characterized by a hypermetabolic state, which is triggered when the patient is exposed to some anesthetic agents, e.g. halothane, especially when combined with succinylcholine. The last item is heme enzymes abnormalities, that may induce porphyria. This will be discussed in the next slide. In order to understand hepatic porphyria, we need to understand the steps of heme synthesis in a normal hepatocyte. The N-type, of the delta-aminolevulinic acid synthase, or simply the ALA-SN enzyme, is the rate-limiting, and the first of the 8 enzymes, in the heme pathway. The heme synthesis pathway contains some toxic intermediates, e.g., porphobilinogen. The end product of this pathway, which is the heme, exerts a negative feedback inhibition on the ALA-SN enzyme. In latent hepatic porphyria, there is a deficiency of one of the intermediate enzymes, e.g. porphobilinogen deaminase enzyme, with subsequent increase of the concentration of the toxic metabolite, porphobilinogen. When these patients receive drugs as phenobarbital, or corticosteroids, which induce the cytochrome P450 oxidase enzyme, there will be much decrease in the heme concentration, since the cytochrome P450 is a heme-containing enzyme. With subsequent loss of the negative feedback, induced by the heme on the ALA-SN enzyme. Accordingly, there will be activation of the heme pathway, with excess production of the toxic metabolite, porphobilinogen, and precipitation of an acute attack of porphyria. Teratogenicity is drug-induced fetal malformations. Teratogenicity is derived from the word teratos, which means monster. It is caused by drugs given early in pregnancy, when the fetal organs are being formed, that is, in the stage of organogenesis. This is usually between the 3rd and the 10th week of intrauterine life, or simply in the first trimester of pregnancy. Each drug is assigned a capital letter, to denote its teratogenic potential. The safest, is assigned letter A, while letter B, means probably safe, and letter C, means that the available data are not sufficient to judge safety. Letter D and letter X mean that the drug is teratogenic. However, in case of drug category D, the physician can use it if it is needed, and the risk is less than the expected benefits. The most famous example of category X is thalidomide, which induces phocomelia, that is, absence of a fetal limb. Warfarin can induce fetal cartilage and bone abnormalities. It is classified as category D, for women with mechanical heart valves, and prone to thromboembolism, and as category X, in case of other pregnant populations. Cytotoxic drugs can induce fetal malformations, that can lead to abortion. Radioactive iodine is category X. it usually results in partial or complete abolition of the fetal thyroid. Tetracycline has been assigned by the FDA to pregnancy category D. When used during tooth development, tetracyclines may cause permanent yellow-brown discoloration of the teeth, and enamel hypoplasia. Withdrawal adverse effects are the adverse effects that occur after cessation of therapy. These may necessitate gradual withdrawal of these drugs. The most common form is that seen in withdrawal syndromes that occur with drugs of abuse, e.g. morphine, amphetamine, etc. The fatal acute Addisonian crisis, or acute adrenal insufficiency, occurs with long-term corticosteroid therapy. The exogenous steroid drugs suppress the ACTH secretion, which is the main stimulant for corticosteroid secretion. Sudden cessation of beta blockers may precipitate acute anginal attacks, arrhythmia, and hypertension. Clonidine was no longer used for treatment of hypertension, since its cessation can induce fatal hypertensive attacks, termed clonidine rebound. These are due to sudden and massive release of stored norepinephrine. Tardive dyskinesia, which are slow writhing movements, occur after sudden cessation of phenothiazines. They are attributed to upregulation of the central dopaminergic receptors.